Good morning, everyone, and thanks for joining us for QI Power Hour this morning. My name is Chelsea Schwartz with the Saskatchewan Health Quality Council, and I'm delighted that you've protected some time to join us this morning. For those of you who may be joining us for the first time, QI Power Hour is a free monthly webinar learning series hosted by the Saskatchewan Health Quality Council. And our aim is to bring together improvers from a variety of sectors with an interest in improving health and to learn about topics related to quality improvement. I just want to acknowledge that I'm joining you today from my home office on Treaty 6 territory and homeland of the Métis. If you know the traditional lands that you're joining from today, we invite you to pop a note in the chat and let us know where you're joining from. We want you to know that all of our sessions are recorded and posted to our website following the event. So we'll invite you to share those links with your colleagues. And while you're on there, check out some past recordings that you may want to catch up on. And while you're on our website, we also invite you to sign up for our distribution list. And this will ensure that you receive notices of upcoming QI Power Hour sessions as they are scheduled. So we say it before and we'll say it again. We are just so delighted that our community of learners continues to grow with over 60 organizations here in our home province of Saskatchewan, over 80 companies and organizations across Canada, and organizations across the world. So thank you again for spending an hour of your time with us and for your commitment to improving the systems that you're each part of. So during the session today, we invite your participation through the chat. So you'll notice that when you joined through audio broadcast. So this means that you're unable to unmute yourself. So if anyone is worried about doing that, not to worry. But we certainly do want your questions. So we'll welcome you to pose your questions in the chat. So you can access the chat function by clicking on the chat icon bubble towards the bottom of your screen. And we'll just get you to send that message to everyone. So this ensures that both our panelists as well as attendees can see the question and we bring everyone along in the conversation. So without further ado, I'm delighted to welcome Brad, Nicole, Josh, and Laura this morning from the Saskatchewan Health Authority. Doug Campbell will also be here to answer any questions. With that, I will pass it over to our panel for this morning.
Thanks, Chelsea. We are here to talk to you today about how we within the Saskatchewan Health Authority are using data to inform our planning. Before we dive in, I'm just going to start with a quick round of introductions. I'm Nicole Ferguson. I am a strategy and innovation specialist within the SHA and part of the strategic planning team. I'm a mom of 2 young, busy boys and have always, born and raised in Saskatchewan, have always called Treaty 4 territory home, and I'm currently in Yorkton. With that, I'm going to pass it over to Laura for a quick introduction.
Good morning, everyone. Coming to you today from Treaty 6 territory. My name is Laura Schwartz. I'm a performance measurement specialist in the strategy and innovation portfolio. Really excited to be here today to speak to you all. And I'm a mom of 2 girls and I got my coffee here. I love coffee, so thanks. Go ahead, Brad.
Sure, thanks. Good morning, everyone. Brad Boudelier. I'm on Treaty 4 territory from Swift Current, a very icy and snow-covered Swift Current. I work as a strategy and innovation specialist as well for the SHA. I've been in the system for about 15 years now, and yeah, had some great experiences working with this team and looking forward to sharing some of that input this morning. So thanks. Josh?
Hi, thanks everyone. Yeah, my name is Josh Marco. I'm an epidemiologist working in the population health department within SHA. So I've been in SHA about 15 years, just like Brad. Been pretty involved in some of the work around metrics at a pop health level, and so I'll be sharing some of that today with you all. And I'm coming from Treaty 6 territory in Saskatoon, and Saskatoon is my area of support within the SHA. So thanks.
Thanks, Josh. And quickly, also on the line with us today, who might chime in during the Q&A portion. So we just wanted to give a quick shout out. We also have Doug Campbell, who's the Director of Performance Measurement, and Robin Shenner, who's the Director of Strategic Planning. So we're going to dive right in. So as you all know and likely understand through your work and possibly even personal experience, our health system is complex. And as this image depicts, our health system requires many system partners working together to improve access to services and ultimately the health of the population we serve. Different layers of government, regulatory, legislative efforts are required. Different organizations, health system partners, SHA being one, Health Quality Council, others across the province, and also other stakeholder groups, community health foundations, other community service groups that all ultimately work together to support the health of the people in our province. Within the Saskatchewan Health Authority, we strive to focus our planning on achieving progress towards our vision, or as Simon Sinek's Golden Circle demonstrates, our why, which is truly healthy people, healthy Saskatchewan. We strive to provide patient and family-centered care by working together in the spirit of our organizational values, safety, accountability, respect, collaboration, and compassion. And so what does our planning process look like within the Saskatchewan Health Authority? Well, the process steps themselves are not overly surprising, starting with understanding our current state. Where are we today? What's that environment we're functioning in as an organization? Moving from that assessment onto making strategic decisions in order to define our strategic focus areas or goals, determining our priorities and plans for the year, and those actions that are needed to achieve the outcomes we've set to achieve. And finally, also focused on what are those implementation or deployment plans and managing our performance through our implementation and constant monitoring of our outcomes. What you're going to hear a little bit more today from my colleagues and I is how we're maturing that first step in our planning process. So understanding our current state. Prior to our executive leadership team and board retreats this fall, a cross-functional team worked together to build a data package, what we referred to as our strategic planning placemat or environmental scanning placemat, you'll hear us refer to it as. And it really outlines that current state internal and external environment that we're functioning in to better inform our fall planning activities. With that, I'm going to pass it over to Laura to dive a little bit deeper into the work.
Thanks, Nicole. I think you just need to pass me the ball so that I can advance the slides. But I'm going to start talking with you all today a little bit more on monitoring the performance within the SHA and using the driver diagram concept connected to our health system indicators to monitor that performance. So quickly, just to tie it back to a previous QI Power that Doug Campbell gave on using driver diagrams to tackle wicked problems within the healthcare system. So we do use driver diagrams in measurement as well. So this graphic is a depiction of a driver diagram. On the left-hand side, we have our aim or kind of the goal of our project. And then further to the right, we map out what our primary drivers and our secondary drivers are to influence that aim or that project. So recall that the driver diagram is a tool for organizing and displaying our theory for improvement in a project. It helps illustrate what is required to change in our system in order for an improvement to occur, and it helps make it explicit the relationships between what you want to accomplish and what you believe will have the greatest impact on how you get there. So we can also embed measurement within these driver diagrams. And as you can see in this image on the slide, we can attach measures kind of to virtually the entire driver diagram, from the aim to the primary driver and the secondary drivers, and even more if you have additional drivers mapped out. So these measures really do help us to track and understand how we're making progress towards that ultimate aim or that ultimate goal. And I'll kind of show you how we do that within our performance measurement system in the SHA. So what is our health system indicators and our performance measurement cascades? So the intent of the health system indicators and the measurement cascades, which you're going to see the cascade on the next slide, it does look a lot like a driver diagram, is to give us a good high-level overview of what's happening within our health system and how we're performing. And it really allows us to see, you know, at a glance where we're performing well and where perhaps there could be areas for improvement. They also allow us to kind of understand how we're performing nationally to other provinces and jurisdictions within Canada. Later on in the presentation, Josh is going to give us a few examples of some reporting that we're developing for those that kind of exist at a bit more of a local or operational level, allowing them to understand, who their population is and identify areas for improvement at that local level. But for now, we're going to stay kind of here at this provincial level and talk a little bit more about how we monitor our performance there. So the health system cascades were created using these 17 statements that are common amongst a high-performing health system. So for example, a high-performing health system reduces the number of chronic condition admissions to our hospitals. So for that, we've attached our health system indicator, a high-level measure as ambulatory care sensitive condition admissions. So I'm going to show you on the next slide what that cascade looks like. But this work with the cascades was really designed to bring attention to the performance of our health system and health system delivery across a broad spectrum, including social determinants of health, what's happening in our community, along with acute care. And this work was completed shortly before COVID and was a joint effort between the SHA, the Ministry of Health, and the Health Quality Council. So here is our cascade over here on the right for ambulatory care sensitive conditions. So why do these indicators and cascades matter? While our overall health system indicator helps us to identify where we need to improve, but that more fulsome performance measurement cascade, it really helps us identify what we need to do to improve. So let's take the ambulatory care sensitive conditions as an example. Our goal is to reduce these. These are admissions to our hospital for chronic conditions, and with appropriate care in the community for chronic conditions, a large proportion of these ACSC admissions could be avoided, especially for those under the age of 75. So what we've done is we've created these cascades using the logic of a driver diagram. So we've plotted out the primary drivers, the secondary drivers, and even tertiary drivers that influence ambulatory care sensitive condition admissions to hospital. That's quite a mouthful. I'm trying to say it clearly, but I apologize. I'll probably use the acronym a few more times. And what we can do to improve or reduce those admissions. So just to kind of talk through the logic a little bit more, if we want to improve the rates of admissions, then we might want to look to improve appropriate and available resources in our community. That's a primary driver. Further down the cascade, we have a tertiary driver about connectedness to a primary care provider. And there is where we've attached a bunch of measures to understand how we're performing as a health system in that area. Things like the number of family practice sensitive condition visits to our emergency departments, the number of people who are reporting that they can get an appointment on their day of choice. That helps us measure our connectedness to a primary care provider in the community with the theory or logic that if we're able to improve that driver, track it through those measures, those improvements will cascade up to the higher health system indicator of ambulatory care sensitive condition admissions. So we really do use the cascades and the driver diagram concept with the cascades to break these larger health system outcomes, such as the ambulatory care sensitive conditions, into smaller, more manageable pieces to identify areas for improvement. And how do we identify those areas for improvement? So we do plot the data. So for example, family practice sensitive condition visits to our emergency departments, we do plot that data over time on graphs such as control charts and run charts that will help us understand whether or not we're improving in those areas or worsening. And we can use those charts to really identify where things maybe need a bit of a change to get us back on track. So, we do know that this level of data is useful for a certain audience and that it's a bit more provincial in nature, and that there is value in synthesizing the information into different formats for different purposes. So next, I'm going to pass it over to Brad to talk us through how we created that Placemat document that Nicole referenced at the beginning, using similar data to what's in the Cascades, but synthesizing it in a different way for a different audience and for planning.
Awesome. Thanks, Laura. So in August of 2022, it was identified that an environmental scan document was needed to support upcoming strategic planning sessions with the SHA Board of Directors. So we identified at the start a few fundamentals that would guide this work. These fundamentals included painting a picture of the current state using several different data sources that needed to be combined into a single planning document. One of the key things was that the document needed to be easy to read, easy to understand, and easy to digest. And with different data sources being pulled from different areas, we needed to bring everything into a consistent look and feel that was reflective of the SHA's visual identity standards that have been developed. And I'll point out that a key element in the document, which I'll share in more detail, was calling out how the data and information would be used to inform planning efforts. So we put a specific content box next to each section within the document, and that content box, or call-out box as we call it, was used to highlight possible impacts on planning. We determined that the document would be distributed both electronically in advance of the meeting and also through the use of printed copies that would be available during in-person strategic planning sessions. So after factoring in all of those fundamentals, it led us to the decision to use kind of a restaurant-style placemat document, is what we would call it, on tabloid-sized 11 by 17 paper. So I'll switch over just to show. We started with I'd call it a wireframe design, which is shown here pretty roughly. So what we did is we started loosely with the ability to shift things around. So we could easily identify the main sections of content that would need to be on the placemat, and also importantly, in which order we wanted them to appear. So we created a quick visual that allowed us to still kind of easily move things around and adjust things to best communicate the story that we were trying to tell. And then you can see there, we also factored in those impact on planning call out or content boxes that I referenced earlier for each individual section. So on this slide, you can see those call outs are in blue. I circled them in red just so you can easily see them for demonstration purposes, but the intent was to have one of those for each section of this eScan document. So after we kind of worked through this and shuffled things around and tried to get things laid out in the best way that we could, that made the most sense, we moved on to the next stage, which was fully developing the placemat and finalizing it. So I'll switch over to this screen here where you can see most of the finished product. Some of the sections will look blurry to you, and we blurred a few items out just due to the presence of some internal and in some cases confidential information. So it might not be completely legible to you, and it's also going to look small on the screen. But in real life, keep in mind, these were on big tabloid size 11 by 17 sheets of paper. And I will point out too, you can clearly see those impact on planning boxes that are next to each section. We ended up changing them from blue to yellow, but it's pretty obvious how one of those with some analysis is assigned to each individual section of this document. So I'll just point out too, you can see kind of in the blue titles there some of the sections that we included within this. I'll just call out some of those specifically that were included. So we had our performance, we had the health of our population, we included some emerging trends and hotspots, benchmarking our performance, which was specific to other provincial health systems and some national measures. And we also included the health of our infrastructure and the health of our operations. And then lastly, I'd flag that wherever it was possible, we also included data comparisons over a number of years and tried to highlight what we felt were general observed trends, both positive and negative. So just trying to give some visuals of kind of the good and the bad that we were planning around. So That's a snippet into what this placemat looked like. I realize you may not be able to make out everything that's within there, but it does give an overview of what we had included. So with that said, I'm going to hand it over to Josh, who's going to dig in a little bit more to some of the indicators and some health network profiles work that we want to call out. So Josh, over to you.
Thanks, Brad. And I find it interesting that we called it a placemat document. I have yet to eat food over top of this placemat because I wouldn't want to. It really is actually a work of art, and Brad's done a tremendous job in terms of pulling together really disparate pieces of information into something pretty readable and pretty captivating, actually. So yeah, as Brad mentioned, I'll go into a little bit more on the indicator piece. My background is more in population health. Like I said, I've worked in the area for about the last 15 years, so that's kind of what I know best. And it's actually a pretty important part of this placemat document. We sometimes refer to some of these metrics or indicators from a population health perspective as our North Star or guiding metrics, which is important because I think some of us can get pretty wrapped up in the day-to-day operations, wait lists, just general workload. But it's important to remind ourselves of what we're actually trying to achieve within SHA collectively and within our communities and the province as a whole. So I think that being said, it's also important to figure out how we situated the information in the placemat and with some of our other products. I tend to go back to this framework. It's from Chronic Disease and Injuries in Canada, published almost 10 years ago, but Public Health Agency uses this as their chronic disease indicator framework. It's also utilized for the most part in mental health, and it can also be used for other types of diseases and conditions. And it's almost like a driver diagram, but kind of almost in reverse. So it takes a life course approach. So right from birth to death, which is what you see on the top. And some of the early year factors, like right after birth, we're looking at socioeconomic factors, education, income, employment, environmental factors, our built environment. I mean, climate change is obviously a huge issue as well. So some of those things in green, and these early year factors in terms of low birth weight and maternal and perinatal influences really set the foundations for health early on. Those things can then contribute as people age to behavioral risk factors. So here we'd be thinking about things such as smoking, drinking, physical activity, nutrition. The accumulation of those risk factors can then lead to risk conditions. So not necessarily full-blown disease, but you're on the path essentially. So things like high blood pressure, overweight and obesity, high cholesterol levels, etc. As we move into the brown box, as we age, then we start thinking about chronic or actual diseases. So these can be chronic diseases, whether it be cancers, heart disease, mental health conditions as well. And then depending on what that disease state is, as you move into the gray box and how long people live, the burden of illness will then take place, and thinking about disability. So really from a life course perspective, we tried to think about this logic when we were presenting the information in the placemat and other documents. It's a good thing to think back and remind ourselves of how diseases and that kind of thing take place over the life course. So with the placemat document, we started really here with the demographics, some basic population and social determinants information. So we included essentially just 6 maps here. This is all coming from census information from Stat Canada in 2016. On the far left, you'll see our population total, as well as our elderly population, 80+ years. Anything dark is sort of higher counts, and lighter is lesser. In the middle, we have our Indigenous identity. So you can see a lot of population in the northern part of our province. Recent immigration. So these are folks that would have come to Canada within the last 5 years, mainly centered in our urban areas of Saskatoon and Regina. And then on the right-hand side, we've got a couple of social determinants indicators in terms of our education, those that have at least a post-secondary education. So you can again see in our urban centers, that's a higher numbers there. And then housing repairs, sort of poor housing conditions. So you see a little bit more of that situation in the northern parts of the province. So again, sort of lays the foundation for health. Not everything, obviously, but we wanted to include this as that starting point. And I'll get back to, you'll see that this map of Saskatchewan is broken out into various boundaries, and I'll talk about that in terms of health networks in a little bit. Next, we moved into what we call the health of our population, and these are sort of a mix of risk and protective factors. We've got some early life and risk conditions information in here. So all of this is coming from the yourhealthsystem.ca website, so it's freely available publicly. All of that except for our early years. So we included at the very bottom, this would be information that's coming from provincially from our kindergarten assessment data from the Ministry of Education. But up near the top, sorry, you'd see heavy drinking, physical activity, cigarette smoking, as well as obesity. So we included this subset. We also included the Saskatchewan values as it compares to the rest of Canada. As you can see, we don't fare overly well in any of these indicators. And then as we move forward in terms of outcomes, we included a few things here. Immunization coverage is not really necessarily an outcome per se. It's more of a service indicator that we are tie a lot of our work to in primary and public health. So immunization coverage rates. Syphilis, HIV, and tuberculosis were identified as strategic priorities within SHA from a public health perspective, so we've included those. And then drug toxicity deaths has really come to the fore recently, especially since pandemic has started. So a lot of efforts and energies are going into providing services and trying to prevent some of these drug toxicity deaths. So not showing any of the actual data here again, because this is sort of internal at this point in time, but this is just to give you an idea of here's some of the outcomes that we were looking at within the Placemat document. So, so with that, that's all I really wanted to say on that in terms of the Placemat. The Placemat document is more geared at the provincial level in terms of scope, but we do know that we've been tasked, and a lot of folks working in primary care and within the system in general need something a little more granular than just provincial level data. So I'll just switch gears a little bit to some of the work that we've been doing really since 2019 with our health networks, and we've developed what's called health network profiles. So as I mentioned, our local planning teams need this more granular data, like provincial data just isn't going to cut it. So we've included really, I would say, many of the same domains, same indicator types as the Placemat document. We just kind of group them differently. But I'll just take a step back, and really we could probably talk about health networks as its own complete power hour because there's just a lot to it. So this is a very summary slide, but the idea with the health networks, they're collaborative teams of health professionals, physicians, community partners, providing fully integrated services to meet the health needs of individuals and communities. And the mission with the networks is to provide the right care at the right time from the right healthcare providers close to home as possible. So it really encompasses everything from our community based services right to some of our tertiary services within the system and everything in between. You'll notice that the map here is broken out into what are the health network boundaries. There are 38 of the health networks in the province. Saskatoon has 5 of them. That's not easily seen on the map, and Regina has 4. So within this is kind of the scaffolding, I guess, for our reporting. Generally speaking, we are defaulting really to the networks themselves. So the networks will roll up into what's called 6 integrated service areas, which is more on the white lines. And so they can roll up, and then we can also break them up even further to what's called small area geography. So we know that people often will say that networks themselves are actually too broad, so we need something even more granular. So we've included small area geography as well. So when the networks were established, One of the first things we did back in 2019 was to provide information in terms of like who's in the networks and what are some of the main health conditions that were included in each one of those. With pandemic, we really did not get a chance to refresh that information until now. And so we are actually right in the throes of updating the information and putting it up onto more of a web-based interface. So what I'll show you next is, this is all really draft and it's still to be completed, but I'll just give you a sense of what we are planning to include in our profiles. So the first section, it'd be very similar to what we did in the Placemat document. So it's sort of a overall about the network. So what's the population of your network? What's the age sex breakdown in this graph on the right here? We do have population projection information at the network level, our recent immigration and our Indigenous identity populations as well. Within each of these network highlights page, we will have kind of a short pithy statement at the bottom in terms of just summarizing what that looks like. And then also within each of them, it will be a network metric in terms of a comparison then to the area and the province as well. The next section would be around social determinants of health. So income, education, employment, so sort of the core SES functions, as well as housing. Early years evaluation, we don't have an early years section. We've kind of thrown this in here. We might want to do that, but these are sort of some of the key ones from a social determinants point of view. Moving now, when we think about that framework in terms of our outcomes and diseases, so this is just a snapshot again. This is pretty draft, but from a population health perspective, we'll be looking at all-cause mortality and some of the leading causes of mortality within each network. Our immunization rates, we'll be looking at everything from 91 days right to 7-year coverage rates. Communicable diseases, we will have a few here, mostly on the sexually transmitted infection side. And pretty happy with our updates to the profiles now because we didn't have these two components last time we did it. And then chronic diseases, we will have at least 9 from our Canadian chronic disease surveillance system, broken out by health network, and we also are just incorporating some cancer prevalence data. So we will have a fairly solid suite of information on the chronic disease side of things. And then finally, because we are working hand in glove with a lot of our acute care partners, and as Laura mentioned in her presentation, so from an inpatient perspective, we will be including things like ACSC and ALC days. They have definite links to primary cares in the community. Again, looking at it from a network, area, and provincial perspective. And then finally, from an emergency department viewpoint, looking at CTAS 4 and 5, so sort of lesser acute conditions in the emergency department, and then family practice sensitive conditions. So if we had really good primary care in the community, we'd expect some of these visits to emergency departments to be lesser in that respect. So again, it's this is really draft. We're aiming to have at least a good chunk of this information available by the end of this fiscal year, working with some of our digital health colleagues to get that rolling. So I think that's it for me. I'm gonna pass it now to Nicole to finish off the presentation.
Thanks, Josh. So back to taking what Laura and Josh have shared with us and how we've taken those data packages to inform our planning within the SHA and using that data to really guide decision making. So once the eScan was completed, we really did put it right to work for us as an organization. Our executive leadership team and board reviewed and discussed the provincial data package, the eScan Placemat, at September and October planning retreats. And those conversations focused on reviewing the data and defining the impact that we want to achieve by 2028. So doing some multi-year focus planning and validating, again, for us as an organization, if our annual goals were still, in fact, the right areas of focus to position our teams around. We also used the Placemat at our December quarterly review, where our executive and senior leadership teams discussed and refined our year-end targets that are just in the process of being developed for next fiscal for 22-23, or sorry, 23-24. I'm a year behind. And so after review of the data and working together as a leadership team, we really did land on the fact that our goals that we currently have really are the right goals. Our healthcare teams around the province are essential for delivering on our commitment to providing safe, high quality, patient-centered care across the province as close to home as possible. And the data continues to show that we must remain focused on our workforce planning, including determining where we have gaps, implementing integrated strategies that align the right people with the right skills to the right jobs on the right team. And also for connected care, the data continues to show that it is critical that we continue to develop priorities and solutions to improve system flow across our centers and shift care towards the community as appropriate, such as within our connected care strategy and further developing our health networks across the province. When it comes to information and infrastructure, health information and infrastructure continues to be a significant focus area for us. Ensuring our systems are supported and up to date, clinical information system consolidation, and improving information flow across the health system continue to remain top priorities. When it comes to the health network profiles, just as the eScan Placemat was used to inform strategic planning at the executive level of our organization, the health network profiles, as Josh described them, are intended to guide that localized planning and decision-making about health services and access to care within those health networks. And so as we aim to mature health networks across the province, health network plans are being developed by teams and beginning to incorporate those health network assessments, the network profiles, our engagement framework, other data sources to help refine those population health approaches to targeting key objectives and outcomes to achieve in those local areas. So with that, that brings us to the end of our presentation today. And we're going to pass it back to the Health Quality Council and I think Laura to help field any questions that you might have. All of our contact information is also up on this slide if you do have any follow-up questions directed to any of us today.
Thanks, Nicole. There was a question earlier in the chat. Doug, you did answer it, but I wonder maybe this won't be, I don't think the chat is posted as a video, as part of the video. So there was a question around, are the health system measures common across the continuum of care, acute care, primary care, long-term care, et cetera? So this is relating back to those health system indicators that I spoke to earlier. I wonder, Doug, do you want to just elaborate on what you posted in the chat quickly?
Sure. So I guess I can go back because I was part of this work when we started in 2017. And what we did when we were trying to figure out those health system level indicators was a broad e-scan across the country and across the world as to what other health systems we're looking at. So we looked at Alberta Health Services, we looked into Ontario, the NHS in Britain, New Zealand, Intermountain in the United States, and got a very large list of what was being looked at kind of that system level. There was hundreds of measures, and as I kind of said in the chat, there wasn't a great thread of like, oh, these are the obvious 5, everybody looks at them. So we took the list, saw what was more common, and then put that into the Saskatchewan context to say, like, what are we working on around primary health care, acute care, continuing care, population health, public health, and tried to pick the right set of indicators that would give a system level view across the entire spectrum of health, and so that we as a health system could impact that. And I think that's kind of where we've landed in a pretty good spot with those indicators. We're actually doing a bit of a refresh right now and just another e-scan to say, are these still the right ones? Have we missed anything that's new because of COVID? Are these still relevant? So while we don't refresh them that often, it's worth taking that look every few years to say, are we missing something? And while if you look at the indicators themselves, you may not see different pieces of this, I would be confident that as you dig down into parts of it, you would absolutely see every part of the system as you get lower in the measurement cascade. So things like alternate level of care days very much relate to access to continuing care as part of it, among other things. And then health and well-being at the end of life, of course, has lots of components to do with seniors care and community care and continuing care, which I don't expressly see as an indicator. It's very much very drivers.
Thanks, Doug. If anyone else has any other questions, please feel free to pop them in the chat. Oh, I see some are coming in now. How do predictive modeling based on network data, for instance, the number of people with diabetes, potentially develop chronic kidney disease? How do we use predictive modeling? I don't know if we use, Doug, would you say we use predictive modeling for that specific of an example yet?
There's none that I know of, and maybe I'll turn it to Josh. Do you know any modeling around chronic diseases that's occurring?
Yeah, I've seen it certainly nationally. They've done some work like with diabetes, kidney disease as well. It's been a while since I've looked at that. It would be an interesting question. I feel like predictive modeling for diseases is a bit of a holy grail for us, at least on the chronic disease side. We do have a modeling division within our digital health department that's done a lot of work with COVID, for example. But it'd be interesting to see if they've got plans afoot to look at some of these more chronic conditions, because I think that is would certainly be useful and helpful. We do have some, I kind of glossed over it maybe a little bit with the profiles. We do have population projection information. So at least from an overall population at a network level, we can break that down into age, sex categories. So that can help a little bit. But in terms of disease predictive stuff, we haven't really engaged in that outside of COVID, I would say.
Thanks, Doug and Josh. From Nicole, there's a question around the health network profiles and if First Nations Métis Health is involved in the review prior to publishing the profiles. Yes, they are. The First Nations and Métis Health and Relations portfolios are both active members of our teams as we're working to refresh these profiles. So they are definitely involved every step of the way there with us for that. Josh, I wonder if you can answer this question from Howard around the First Nations and Métis populations being reported as a part of the whole population, but will this statistic also be available as a percentage of only those receiving services?
No, so Howard's right. Like each of the networks will have First Nation communities would be involved in the population totals, but we're not parsing them out separately. The only, I guess, aspect of that we are doing it for First Nation and Métis populations is around the census, and so we would have an overall census count for that. But in terms of services and service delivery, we aren't really going to be doing that level of stratification for this cut of the profiles. If that's the question, Howard, I'm not quite sure.
Thanks, Josh. Howard, if you feel like, he says yes, we answered it, so that's great. There's a question for Melanie around speaking to how patient experience and engagement indicators are included in this work. So that's a great question. And I'm not sure if there's any of our patient and family specialists on the call today, but we are working, the strategy and innovation portfolio is working in partnership with that portfolio to begin to develop some patient experience measures. So we are in the process right now of piloting a patient experience survey at the health network level to kind of get a broad population sense of how patients are experiencing care within their health networks and their communities. So that work is kind of unfolding right now, and once we have some data, it will be included in those cascades that I showed earlier in the presentation. And then I am aware of a few projects kind of across the province that are, applying some specific interventions related to what's happening in their community and using some patient-reported experience and outcome measures to understand what their patients report as their overall health and their experiences within the community. Yeah, Chris Pliszka, thanks, Jennifer, is leading that work. Would there be any movement towards public reporting of these health system measures? I'm going to pass that one to you, Doug.
For sure. So the ultimate goal is, yes, absolutely. Like that's where I would like to get this, along with I think everyone on this call. We'd like to be able to show all of what we did publicly and have a publicly accessible dashboard. At the moment, some of those health system indicators are available publicly, whether they're through CIHI or Stats Canada. Some of them you can go on and find. You can see exactly how Saskatchewan ranks. Others probably are still have some privacy things with it, which is why we didn't share them. For the dashboard that Josh was sharing around the health network profiles, Laura did put a link in the chat around the first ones that we did in 2018, so you can see exactly what data we had there. As we move to this more digital format for these health network profiles, the plan is to again have a PDF version that'll be shareable and can be used publicly. And then we'll work with our partners at the Ministry of Health and through the government to understand the steps that we need to take to move parts of that dashboard forward to public reporting if we can, understanding that things like our HR information and finance will probably never be reported publicly, but some of these other health system measures absolutely could be. But kind of in the interest of getting it up and off the ground, we've started small and it'll be available internally to the SHA. And then the next step would be to partner organizations like the Health Quality Council, SAS Cancer Agency, and then maybe community-based organizations and physicians would be after that. And then we'd go as broad as we could. So it'll be a stepped process that we need to work through, but that's absolutely the long-term goal, is to do as much of this publicly as we possibly can.
Oh, thanks, Dwayne, for putting the health system CIHI information link in the chat. There's a question from Bev around with the growing elderly population and immigration population in rural Saskatchewan. Will there be more in-depth gathering of rural program data? So I might need you to elaborate a little bit more on what you mean by rural program data. But I'm not sure if Doug or Josh, you can report on like plans to embed data collection at that more, I guess, local level across the province. We kind of need somebody from digital healthcare, I feel like, too.
I could just take a quick stab at that one. And I think even within the consultations from the first go around with the profiles, we were really deliberate to ensure that we were including data that was sort of standardized and as comprehensive as it could be across the province. We knew that certain areas of the province had better data than others, and in those situations we elected really not to include it in the profiles because we wanted it to be, again, as complete and standard across all networks of the province as possible. So but certainly as we've been rolling out some of this information, inevitably people will want to see more. Like, what about mental health and addiction service data? For as an example, that MHAIS system is not a provincial system. It's kind of, it's embedded or it's operational in certain parts of the province and not others. So that's sort of a hesitation in including program data that exists in one area and not others. So the only thing I would say is that the profiles work itself is not the be all end all. There will always be needs outside of the profile. So if people really want to dig into a particular program or whatnot, then that's where other supports like ourselves in population health, digital health, strategy and innovation can help to kind of bring that information to light. But it's probably not going to live in the profiles itself because it's really meant to be a provincial kind of viewpoint.
Thanks, Josh. There's a question from Tanya in the chat around the network profiles being rolled up to see kind of what's happening overall in Regina and not just the 4 separate networks. So yes, that is the plan. So we're currently in the process of really working through this online dashboard to make an interactive tool for people to be able to kind of roll up and drill down into different areas to understand what's happening. So the plan will be to be able to see Regina as a whole, as well as if you want to zero in on exactly what's happening in Regina 4, you can do that too. A question from Megan around, it would be helpful to see health system indicators for people with disabilities. Is there any work being done to evaluate patient experience for populations with physical, intellectual, or developmental disabilities, That's a really good question. I don't have the answer right at my fingertips. I know, Hazel, you're, I think, an attendee unless you had to leave. If you can recall off the top of your head if that question is being included. I know, you know, we are asking some questions around physical conditions that a person may be experiencing that might influence their health and the care they're seeking. I'm not sure about the other types of physical, intellectual, or developmental disabilities. Or if Doug or Josh, you remember off the top of your head, feel free to jump in. We can definitely look into that further, though.
No, nothing more to add from me. I'm not aware of anything, but we can definitely do some follow-up and figure out what that answer is.
Yeah.
Yeah, nothing more from me on that one. Thanks.
Well, and Hazel just put in the chat that it's not included as far as I know. But excellent flag, and Hazel and myself are a part of that working group, so we are very able to raise that question and that flag to the broader group. So thank you, Megan. I'm not seeing any more questions popping into the chat, but it was really fun to see so many come through. So hopefully you feel like we were all able to adequately answer them. If not, our email addresses are included in the slide deck, so we would be very happy to hear from anyone with some further discussion on what we've covered today. Maybe I will pass it back over to you, Chelsea, to kind of close us out.
Perfect. Thank you so much, Laura, and to you, Brad, Mark, Doug, Josh, and Nicole. It's been great hearing from you. This is fantastic work that you're doing. I'm going to have to go back and listen to this all over again because you shared just such a wealth of information in our short time together. So as Laura mentioned, their contact information is in the slide deck. And you may have missed it in the chat, but I did post a note that the slides are available on our website already, so even before the recording of this session. So if you'd like to go back and take a peek at what was included in the presentation, you're welcome to grab that. And we are delighted, as always, to offer our guests today these lovely socks. So I know a few of our presenters have a bit of a collection of these socks based on the number of QI Power Hours that they've done. So perhaps that should be a goal, to have a pair of I Love QI socks for every day of the week. If you want to get your hands on a pair of these lovely gems, we invite you to become a QI Power Hour speaker. So I'll get Lisa to drop a link in the chat to check out how you can do that. We love hearing, we love folks coming forward with their ideas of items that they'd like to share with our learning community. So we look forward to hearing from you. And in the spirit of continuous improvement, we will be asking for your feedback on this session today. So you'll notice that you'll get this little prompt at the close of the session. It is a safe site, so we invite you to click through continue to provide your feedback on the session today. And we are in the business of practicing what we preach and using feedback to continuously improve our offering of QI Power Hour. And in terms of a heads up for what we can expect for next month, we have Christopher Morasti joining us from Men of the North, which is a male mental health support program. And that will be just in a couple of weeks here on February 10th. So same time, 9:30 to 10:30 a.m. Central Time. So again, thank you so much to our speakers today. Thank you for our attendees for joining us and all of your great questions. And we'll see you again next month. Take care, everyone.